Hello, and welcome to episode 31 of the MedEdit podcast, your ultimate resource for evidence-based medical education. Today's episode is very special. I'm joined by my good friend, Dr. Vanessa Costilla, as a special co-host to talk inflammatory bowel disease and its impact on colon cancer. She's a fabulous gastroenterologist, like myself, but she's practicing here in Lubbock as part of the UMC health system. This episode takeover is in honor of Colon Cancer Awareness occurring this March and every March. We will miss Dr. Gray this episode, but Vanessa, it is good to have you on with me today.
Hello, and thank you for having me. I know this topic is near and dear to both of us. We have some studies showing a frequency rate of colorectal cancer and inflammatory bowel disease ranging from 1.5 to 2.1%, or even slightly higher, compared to 1.2% among the general population.
IBD is truly fascinating. We will talk about what defines inflammatory bowel disease, how it is diagnosed, symptoms, primary treatment options, and lastly, the risk of colorectal cancer. We are your hosts for today, Dr. Cari Sorrell
and Dr. Vanessa Costilla.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
Okay, we're going to start with defining inflammatory bowel disease, or IBD, as we'll call it from now on, so we don't have to have a mouthful. IBD is a group of chronic conditions that cause inflammation in the gastrointestinal or GI tract, as we like to name it. What this basically means is that IBD is thought to be an autoimmune disorder, where your body's immune system mistakenly attacks healthy cells in the lining of your GI tract. This abnormal immune response leads to chronic inflammation in the intestines that cause symptoms and complications. The two main types are Crohn's disease and ulcerative colitis. The exact cause of IBD is actually not known, which is kind of strange, but thought to be due to a mixture of many things, including genetics and environmental exposures. This means that certain genes have been linked to an increased risk of developing IBD, and then we know certain exposures like smoking, antibiotic exposure, and even dietary factors like a diet higher in fat or a higher sugar diet may trigger IBD in individuals who are already susceptible. There's also been some evidence that exposure to certain infections or stressors during childhood actually increase your risk of IBD, as well as having a gut microbiome with a certain concentration of certain bacteria. Your microbiome are those bacteria living in your intestines, but this is still something of ongoing investigation.
IBD is a gastroenterologist's bread and butter, as it can affect anywhere in the GI tract, from mouth to anus, as well as other parts of the body, such as your joints, eyes, and skin. As you mentioned earlier, IBD is truly fascinating. We mentioned you have genes that make you more susceptible, but most people with IBD have no family history. Also, some people get symptoms at a young age, and some don't get symptoms or get diagnosed until they are in their 50s and 60s or even older. My oldest inflammatory bowel disease patient was about 80 years old.
I know. That's crazy, isn't it? Like they go their whole life with
Yes.
susceptibility and then something triggers it that we don't quite understand. It's very interesting.
Very interesting.
And it's something we both see very frequently, considering the prevalence in the US of IBD is anywhere between 2.4 or 3 million people. We do see it more in Caucasians, but it can affect anyone, as we have seen. I always thought it's so interesting that cigarette smoking is the most controllable risk factor for Crohn's disease. But in contrast, we know that it can help prevent symptoms in ulcerative colitis, which we're not saying, we know the overall harm to your health outweighs any benefit from smoking, and quitting smoking has many health benefits. So we are not telling you to start smoking if you have ulcerative colitis, but it's just very interesting. Again, that's why it's such a fascinating disease. Ulcerative colitis and Crohn's disease differ some, but overall symptoms, the diagnostic evaluation we do, and treatments are similar. So we'll talk about them together and we'll highlight differences. So Vanessa, tell me a little about Crohn's disease and ulcerative colitis.
So as you mentioned before, both can affect any part of the GI tract, but Crohn's disease most commonly affects the small intestine and the beginning of the large intestine, whereas ulcerative colitis really only affects the large intestine. Symptoms of both can vary depending on the location and the severity of inflammation. But common symptoms include the following: persistent diarrhea, abdominal pain and cramping, weight loss and reduced appetite, fatigue and weakness, blood in your stool, mouth sores, fever in severe cases, fistulas or abscesses, Fistulas are basically abnormal connections between organs or infected pockets, joint pain, and skin rashes. We call these extraintestinal symptoms.
All right. And I know that we know this, but let's tell our listeners, how do we diagnose Crohn's disease?
So, diagnosis of Crohn's can include doing some blood tests to check for anemia, infection, or markers of inflammation. You might have seen a test called a CRP or an ESR. That's something we would check. There are stool tests that we would do to rule out infection, but some of those stool tests also help us detect inflammation. As we both know, the gold standard of diagnosis is endoscopy, including colonoscopy and an upper endoscopy. This is when a camera is inserted into the mouth or anus and is used to examine the intestine for ulcers, inflammation, and bleeding. We usually also take biopsies for analysis. Sometimes imaging tests, such as a CAT scan, MRI, or an X-ray, are also used to help visualize inflammation, strictures, or fistulas in the digestive tract. At times, we also use something called capsule endoscopy, which is a small pill-sized camera that is swallowed to take images of the small intestine. It is hard to reach areas of your small intestine since it's about 17 to 20 feet long with our traditional endoscopes. So we use this camera to take pictures of those 20 feet of small intestine, and we get to watch them from our computers at home.
Mm-hmm. Yeah, and of note, ulcerative colitis is pretty much the same for the most part. It's just the extent of testing you need. It depends on what location we think you're having symptoms and what we target. When we perform these endoscopies, basically we're looking for easy bleeding of the GI tract lining, maybe ulcers, that's where ulcerative colitis come from, or breaks in the lining of your intestine.
Yes, absolutely. And sometimes this inflammation can be so bad we cannot continue the procedure safely, or we might see scarring or strictures forming in the GI tract.
I'm always really surprised when I scope somebody with like a severe stricture and I don't know how they're functioning. And it's like I can't even get a camera in there because it's so scarred down. And I'm just like, I don't know how you're alive right now. It's quite impressive.
It is.
One great thing about inflammatory bowel disease as a gastroenterologist practicing currently, and I guess probably for the last decade, is we have so many treatment options that are available now, and we have new ones coming out all the time. IBD treatments are one of the things that we like to nerd out about. Every major conference we have, that's all we talk about, it seems like. But treatment mainstays overall are going to include medications that reduce inflammation. And they're going to do that by suppressing some part of the immune system. The targets change, but this is called an immunosuppressant. We have some that are really fancy and they target the GI tract very specifically to the point that systemic side effects are actually pretty rare. And also the increased risk of infection because your immune system is suppressed is minimal, which is very impressive, truly amazing. Occasionally, we'll use antibiotics to treat certain complications of the disease. And there are important non-medication things that you can do as well as a patient that we recommend to our patients. And those are lifestyle and dietary changes. And we've talked about before on this podcast how certain diets decrease inflammation, avoiding overly processed foods or ultra processed foods, large red meat consumption, things like that. And these are, of course, the things you would talk to your doctor or your gastroenterologist about. And then occasionally we do need surgery to remove the affected part of the intestine. But thankfully, our medications are so good now that we do that much less commonly than we did a decade ago, which I think is fascinating.
Absolutely.
And overall, we're going to skip to what we're really here to talk about today, which is colorectal cancer. And we covered this last year on our episode, you and I, for our colorectal cancer awareness. So today we're going to highlight inflammatory bowel disease, and that's what we wanted to discuss, the increased risk of colorectal cancer those patients face. But just remember, March is Colorectal Cancer Awareness Month for everybody. And that's why we wear blue, because, we picked a good color for our colon cancer awareness. What's the one? But we have one that's brown, but I always forget which one it is.
Oh.
It's a rare one, but anyways, we would have thought we'd picked brown.
I guess.
Yeah, I think it's pink. No, I think they're purple. I think, yeah, they were smart too. We picked purple and blue for the GI tract, absolutely. But overall, I said it's colorectal cancer awareness for everyone.
Your risk of colorectal cancer could be up to 2 to 3 times higher if you carry a diagnosis of IBD. There are a lot of things we do to decrease this risk, such as being on suggested treatment and undergoing endoscopic surveillance.
Absolutely. And I will say colorectal cancer risk with inflammatory bowel disease is a fantastic example of the power of medical advancement. So I looked at studies from 50 years ago. So really not that long, right? We're not talking about 100 years ago, 75 years ago. I mean, that's many people listening were alive. And they used to cite your cumulative risk of colorectal cancer if you had IBD for more than 25 years as high as 40%.
Wow.
So if you had inflammatory bowel disease for 25 years, you almost had a 50% chance of getting colon cancer. That's crazy. That's high. With advancements in endoscopy treatment and our surveillance programs, that risk has decreased dramatically. And now we see cumulative rates for colorectal cancer with IBD cited at 7% or lower for the same duration of disease.
Wow, that is impressive. That surveillance program you mentioned is us, GI doctors, performing endoscopies usually every 2 to 3 years in these patients to hopefully detect precancerous or cancerous changes very early and intervene. Sometimes special lights or dyes are used to increase the effectiveness of this surveillance. We actually spray your colon with a blue dye to be able to highlight anything abnormal even easier.
And I would, for those who think that, GI doctors just like to torture people, I would like to point out that, and I think this may be even while we were training, that we used to do yearly.
Yes.
For inflammatory bowel disease.
We did.
And studies have come out showing that we can push that to 2 or even 3 years. So we are nice. We are trying to do them less frequently for you and still detect cancer. So don't think that we're doing it as often as it used to be done, where you would have gotten one every year. For all of our listeners, we of course encourage you to talk with your healthcare providers about colorectal cancer screening, and check out the episode last year that we did with Dr. Costilla, and you'll hear all the details about this topic and some stats as well. We don't like to include those, but we're going to include them in the following because they're real.
In 2023, the American Cancer Society, or ACS, reported that in 2019, 20% of colorectal cancer diagnoses were in people under 55, which is double the rate in 1995. The rate of advanced stage colorectal cancer in people under 50 has increased by about 3% annually.
Oh, it's crazy. And in fact, according to 2024 reports, so pretty recent from the ACS, colorectal cancer has moved from being the 4th leading cause of cancer death in both men and women under age 50 2 decades ago to now 1st in men and 2nd in women. We've talked about this before, but it's thought this change has been seen due to a combination of high-fat diets, high processed foods, decreased physical activity, possibly exposure to harmful environmental factors we just don't understand well, and very likely related to our obesity rates that have skyrocketed during that same time. But it's a very hot topic of ongoing research.
Yikes, that is scary. If you or someone you love has changes in their bowel habits, rectal bleeding, even if they think it's a hemorrhoid and it doesn't go away, encourage them to get a colonoscopy.
Absolutely. Well, that concludes a thorough review of inflammatory bowel disease and the increased risk of colon cancer, as well as a very friendly reminder about why colorectal cancer screening is so important. Thank you so much for being my co-host today, Dr. Costilla.
Thank you for inviting me.
And if you are in the Lubbock area, we just would like to mention that our colon cancer awareness run, called the Undie Run, again, because we're gastroenterologists and we have a lot of fun, is coming up soon. And I think, is it UMC has that on their website?
Yes, yes. It's on March 29th at 9 a.m. And we encourage the entire local community to come out and wear blue. And lots of times our runners even will wear their boxers or underwear outside their running pants. And it's a lot of fun to come together and support the Colorectal Cancer Alliance.
Absolutely. Yeah, please do wear pants, though, underneath your underwear.
Yes, please
do not just wear your underwear, and we will both be out there and see you then. Don't forget, if you are a listener claiming CME credit, please look in the show notes for instructions. And all of our listeners, thank you for tuning in. Please like, subscribe, follow us on our socials, share this episode. Let us know what other topics you're interested in through our Instagram and TikTok, and stay tuned for the next one.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.